Hello, everybody. Welcome to week 9. We are just around the 2/3 mark, I would say. We've got about 5 weeks or so to go. So at this point, you should be, again, I use the term should be, lightly, but um, anyway, module 1, the first 3 units, at this point, you should have a pretty good grasp and have moved on from that. Module 2, units 4, 5, and 6, kind of the same deal. I think I've been doing the grading for both courses, course sections, and most of you are at least into unit 5 or 6, if not done with those. So at this point, we're moving into module 3. And before we do, I want to make a note as we head toward the finish line here. So in the syllabus, I'm going to blow that up a little bit. There we go. So in the syllabus, you have the grading scale. So the entire course is out of 1,200 points. And this may be overkill for some of you, repetitive, but I want to throw this in here. You need to be, I think most of you need to be in the B range, which, it says 996. But generally, if you've managed to sustain and maintain and earn an 80% or higher, so 960-ish points out of 1,200, you're likely going to see a B on your, from the registrar and the grades. So, on your report card, I guess. You don't really get those anymore, but your virtual report card. So anyway, really 960 is the bare minimum, I would say, that you'd want to be shooting for. And again, just to reiterate, the how do we get to 1,200? You have 12 Padlets, and again, you just need to do one entry per Padlet. So each Padlet, of course, has 5, 6, 8 different videos. So just at the very least, make a comment under one of those videos, and then you need to go into Blackboard and do the Padlet quiz. Several of you have done that, several of you haven't. So that's 10% of your grade. Comprehend section or the case studies. Most of you, like I say, you're up through at least 4 or 5, if not even done with number 6. So that's good. That's a good spot to be in as we head toward the home stretch. I want to mention too, working ahead, case study 12 is going to be kind of a choose your own adventure. So keep that in mind. If you're trying to get some, if you're crunched for time and you need to do a case study, that one is a really good one to do because you get to really kind of pick your own case study. So you maybe want to jump to that one if you're kind of tired of the same old case studies here. So anyway, you want to get all 12 of those done for 20% or 240 points. And then several of you have completed all of the labs, which again, that's the way to go. At this point, again, there are 12, technically there are 16 labs, but 12 unit labs, 360 points total for those. And then again, 12 exams at 480. So this is kind of your midterm grades have been submitted. This is, again, as we head to the home stretch, I want to reiterate kind of what's going on here and how you're graded and what points you want to shoot for. All right, and then as you scroll down, we see the course calendar again, kind of where we are. Today's the 15th, so really we're just kind of ending, again, ideally, we're ending Unit 7. Today, this video, I'm going to cover Unit 7, Case Study 7. Oh, what happened there? Go through those. Case Study 7. So anyhow, So tonight we'll go through case study 7, and we'll probably get into case study 8. We'll see where we are on time. And then if not, next week we'll pick up at case study 8 and keep going. But again, for case study 12, we're not gonna have to do a video for that. I'll pull it up and piggyback it with number 11 when we get there. But other than that, that's kind of an update as to where we are and where we're going. So let's jump right into module 3. And I'm going to go again just straight to the case studies. You can get to them through the modules. All right, so we need to look at the questions. I'll blow that up a little bit. Looks fine. And then we're going to open up the actual case study. Now, you know, if I open this in Google Docs or even Word doc, it doesn't translate properly. So we're just going to do it right here as a PDF. And again, you know, you can download it. This little icon here will let you download it, and you can view it in a different, you know, in Explorer or Firefox or whatever the heck you use. So anyhow, let's get to it. Tradesman journey. Back from a cerebral accident. So we've got a you know, kind of a relatively common EMT/ER visit here. So we've got Paul mending broken objects and just kind of a fixer-upper type guy. He became an electrician. Unfortunately, a couple of years ago, his father had a massive heart attack. Paul's 57. He's under immense pressure. Needs to find 2 new employees. So Paul's under a lot of stress right away. We can see owning your own business is extremely stressful. Losing a loved one, particularly a parent or spouse or child, someone in your immediate family is of course extremely stressful. So Paul's starting to gain some weight. He's not eating right because again, he's under stress. Certainly doesn't have time to exercise. He's got hypertension. He goes to the doctor, so that's, you know, that's maybe a plus in his situation because of the type of stress he's under. So we see he's got hypertension, which means again he's got elevated blood pressure, and it's a chronic condition. Usually, what goes with that is high cholesterol. So we also see Paul suffering from that. So of course, the cardiologist is going to give him Lipitor, which is in the statin class, and those lower your bad cholesterol. And he takes one of those every day. Doctor discussed some lifestyle changes and eating habits. Again, it's difficult to implement for our patients, but it's good that we certainly talk to them, especially when they're there for a lifestyle disease such as hypertension and high cholesterol. So, so why are we dealing with him today? Well, he's got a severe headache to the point he didn't want to go to work and chose not to. So his wife advised him to take a couple ibuprofen, and it wasn't really helping much, but he finally kind of divulges that he's had these headaches regularly and that they usually subside, and that he's fine. And he's got kind of a muffled or slurred tone in his voice. So his wife is getting a little nervous maybe at this point. So let's see. So Teresa, his wife, she heads off over to the laundry room to check on the laundry, and she's out of the room, and Paul starts getting a little bit more painful in the head. He knows something's wrong innately. So we see that term innately. That means, you know, like internally inside, just kind of his sense that something's not right. He's trying to call for his wife. Nothing's coming out. So speechless, accompanied by numbness on one side of the body, severe dizziness, confusion. Not good, right? So Paul's in a panic mode at this point, but nothing's happening. So he tries to call emergency services, but again, his legs aren't working properly, so he falls to the floor. Teresa's asks him how he's doing from the laundry room. She doesn't get a response, so she figures something's up. So she comes in, finds him, calls 911, ambulance and the EMTs, paramedics arrive. He's at a 158 over 102, definitely sitting pretty high. Responses are limited. Medication, Teresa gives the paramedics everything, and boom, so we get to phase one. All right, we made it. So what should Teresa tell the emergency techs? Well, we've kind of gone through this. She certainly needs to tell them that he's been diagnosed. She needs to tell him who his doctor is for sure, and that's probably on the piece of paper. So that's good. She's prepared. Piece of paper is going to have doctor's name, Medicaid, and she may want to have a couple of these laying around. You know, if she's handing that one off to the paramedics, if that's their only copy, it could get tricky. So anyway, regardless, that's going to have doctor info. It's going to have all of his medications. He's hypertensive. He's hyperlipidemia, which means he's got high cholesterol and fats in his blood. He's taken Lipitor, or yeah, it's taken Lipitor, 10 milligrams a day, once daily. Let's see, father passed away of a massive heart attack recently. Paul is under a lot of stress, running his own business. So anyway, if he's got any allergies, of course, he needs to let him know that. Mechanism of action. So how do statins work? Kind of a brief synopsis of how statins work. I don't think it's, we could probably sum this up in a sentence or two. But in essence, there's an enzyme in the liver that's responsible for the production of cholesterol. It's HMG coenzyme A reductase is what this is called. So if you saw this term, you'd see reductase. So an enzyme that has to do with the reduction chemical reaction. HMG, hemoglobin, coenzyme A, cholesterol. So this is an enzyme responsible for the production of cholesterol, and it's commonly prescribed. So anyway, what the statin is going to do is block that enzyme. So a lot of prescriptions or a lot of pharmaceuticals, that's really their aim or their goal is to go to the chemical level and affect the behavior of the cells. And if for this particular classification of drugs, we know that that they block the enzyme that's responsible for producing cholesterol. So so anyway, that's really all you need to put. We prescribe these statins for hypercholesterolemia or hyperlipidemia, whatever you want to call it. So some physicians use it as a preventative. If you go in and you get blood work done and you got some cholesterol issues, that are borderline, they'll talk to you about diet, and they may put the patient or put you on statins just to prevent excess cholesterol. But again, well, either way, why do we have excess production of this enzyme? That's the deeper rooted issue, and it's likely because of a hyper need for that enzyme. So the more cholesterol or the more lipids or fatty foods that we consume, oil-based foods, these are the non-essential fatty acids, your saturated fat groups. These are going to, if you consume a lot of those, if you consume any, you're going to have a need for this liver enzyme to help with the synthesis and production and manufacture and the delivery of all of these different fatty acids. So cholesterol gets produced by from lipid consumption. So you consume the lipids, your liver is going to convert these lipids or these fatty acids into cholesterols. And one of the enzymes that helps to break down these fatty acids and help with the production of cholesterol is the what gets, I guess, accused of being the problem when it comes to someone having high cholesterol. So anyway, the quick fix and the temporary fix, really, until everything gets back on track, is to prescribe a statin drug. But once you're on statins, generally you're gonna stay on them for the rest of your life. So anyway, diet changes, activity changes, consumption awareness, proper rest, stress management, coping skills, all of those will help with your body's synthesis of lipids and fatty acids. So anyhow, statins are highly prescribed. They're, I would say, the top 10 most prescribed drugs, pharmaceuticals in the United States. At least 3 of those top 10 are going to be statins, and the other probably 4 or 5 of those 10 are going to be hypertension medications, and the other 2 or 3 are probably related to type 2 diabetes. So the top 10 most prescribed drugs in the US are more than likely related to lifestyle diseases. So anyway, Paul needs more than just a glass of water and a nap and a couple ibuprofen. He needs some extreme intervention regarding certainly his stress coping skills, regarding his family situation, his eating and dietary and nutrition and consumption behavior needs to be altered. And I'm sure once that starts to happen, we may see Paul actually not needing so much medical intervention. But at the moment, he definitely needs some assistance. So let's keep her moving. While taking Paul's vitals, emergency techs took his blood pressure. So this asks how blood pressure is taken, and how would you correlate blood pressure with Paul's results and Paul's symptoms. So you can certainly, some of you already do blood pressure readings. Some of you maybe have never done anything with blood pressure readings, which is okay because you're going to be getting a ton of clinical experience in your nursing courses in regards to taking blood pressure. Nowadays, a lot of it is done through machinery, and so anyway, the art of taking blood pressures not quite as in vogue as it once was. So regardless, you should research a little bit and get the basics. You could put them in step-by-step bullets, or you can number the steps, or you can just write a paragraph describing how you would take someone's blood pressure. So make sure you get the name of the instrument that we use, or instruments that we use. Certainly a stethoscope and a sphygmomanometer are the primary instruments for taking blood pressure. And then discuss a little bit maybe about what the numbers represent, why you're taking blood pressure. We have, again, the word pressure is in there, so we're dealing with some sort of movement of a fluid through a closed system that involves a pump. And every time this pump pumps at your heart, or some of your skeletal muscles, we're seeing increases in blood pressure. So in between, or we're seeing pressure changes going up with each pump. So the top number, or the higher number, we call the systolic or systole number. It represents the pressure against the walls of your arteries after a heart contraction. So, or during a heart contraction. So when the heart beats, blood gets ejected from the heart, travels through the arteries, and we see the increase of volume causing an increase in pressure in these blood vessels. So that's the top number. The bottom number is lower, and that's going to show us kind of the resting pressure of against the arterial walls while the heart is filling. So between contractions, the heart is filling back up, and we see that there's still a pressure within the arteries. And again, that low number range generally is between 75 and 90, I would say, or even 70 and 90. 70 and 95 is a pretty big range of acceptability. The top number, generally, we like to see 110 to 125. Once we get above 125 into the 130s, 135, they start talking about borderline hypertension. So anyway, that and the difference between the two numbers, the 120 over 80 has a 40 millimeter of mercury pressure difference. And so when we look at blood pressure as a whole in an individual, we want to know what that distance is between the two. So if I have a patient that's at 120, but their low number, their diastolic number is 65, that may seem like it's okay, but in reality, you've got instead of a 40 millimeter mercury difference, we've got a 65 millimeter mercury difference. So what that means is the pressure on the arteries at rest is 65, but each time the heart contracts, that pressure increases 65 more millimeters of mercury. That would put a lot of excess pressure against the walls and lining of the arteries. So we're not only looking at the top number and the bottom number, we're also concerned about or interested in the difference between those two numbers. So as we continue on, so anyway, you could want to make mention of blood pressure. Oh, and it asks a little bit about this particular patient. Paul, I think as blood pressure relates to Paul, he has a narrowing of the diameter of his arteries due to the hyperlipidemia or the hypercholesterolemia. So he has high cholesterol. It's assumed then that the buildup of cholesterol in the lining of his arteries or in the walls of his arteries is leading to a decrease in diameter. And one thing we know that if we decrease diameter of a tube, the pressure to get the fluid through the tube is going to be increased against that wall. So smaller diameter, increased pressure. So with cholesterol buildup, we're going to have a decrease in diameter. So in fact, that's partly why. So the heart also has to work harder to pump blood through arteries that have some sort of clogging going on. So the heart muscle itself is at more of a risk for heart attack when it's having to work harder. All right, so let's see, where are we? Number 4, what part of the brain controls muscle contraction? Oh, because we also have some issues with Paul's movement. He's got some motor skill problems, so we want to make sure that we're looking at that. So maybe he's got something going on with the brain. So let's see, check my notes. What part of the brain controls muscle contraction on each side of the body? Within that region, what part of the brain controls muscle contraction or movement of the legs? So the primary so we're talking about movement. So in the brain, we see there are sensory regions and motor regions. And these motor regions are where muscle control is coordinated. So within the primary motor cortex, we find that right toward the frontal lobe of the brain. So generally around where the parietal and the frontal lobe and the temporal lobe and the frontal lobe, kind of that whole area right there is where we're going to see this motor cortex. So, so when we get impulses, responsive impulses sent away from that motor cortex, these impulses are going to travel out to the skeletal muscles. So the fact that Paul is having musculoskeletal movement and control issues tells us that we may have a problem up in the motor cortex of the brain. So let's see. And the arrangement asks about arrangement. Generally, again, we see the left side of the brain controlling the right side of the body and vice versa. So this left side, if we have a left side motor cortex injury or event, we would see right side musculoskeletal issues, and some of these may not just involve uh, uh, voluntary movements like we see with Paul. He's trying to walk. He's using these skeletal muscles voluntarily, and they're just not working. We also sometimes will see a decrease in proprioception of the musculature. So, for instance, the facial muscles always have a subtle, and posture muscles of the back, they always have a subtle impulse traveling to them to keep them continually responsive and to keep, for instance, posture or facial expression at a point that it's not sagging, drooping, or falling over. So if we have damage to the motor cortex, it can oftentimes affect proprioception as well. So we may see left side damage in the brain could lead to right side face droopage or sagging. So as well as again postural um, issues. So let's see. So that's generally what we think about for number 4. Number 5 gets into reviewing Paul's history of high blood pressure and high cholesterol. How do you correlate these symptoms with a heart attack or a cerebral stroke? Well, again, we are fairly certain based on his signs and symptoms that he's experiencing some sort of brain-related injury or stroke. His family history shows that there are cardiac issues. He's already been diagnosed as being hypertensive and hyperlipidemia. Now we have speechlessness. So, again, part of the brain that controls speech. He's got numbness on one side of his body. He's dizzy. He's confused. These are the classic signs of a stroke. So, and again, he's got the high blood pressure and the high cholesterol already. A CVA or cerebral vascular accident, also known as an ischemic or an ischemic stroke, can begin with a blood clot as well. High blood pressure. So if he's got high cholesterol in his arteries and arterioles, oftentimes this leads to microclotting going on those basically what happens is you get micro tears in the lining of your blood vessels, specifically arteries and arterioles and even capillaries when we're dealing with high blood pressure and high cholesterol. So these micro tears in the linings of the arteries usually lead to micro adhesions. So these micro adhesions, so basically it's like getting a cut and then getting a scar or a scab, I should say, over the cut. And so the scab over the cut is what we see as blood clots internally. So in the lining of these blood vessels, we're going to see a little bit of tearing, micro tearing, and then we're going to see some micro clotting to stop the bleeding and to fix those tears. And then these clots oftentimes will get loose and travel. Sometimes they clump together. And then if one of those clots heads up to the brain, we could end up having some sort of cerebral vascular accident. So anyhow, that clot can act almost like a dam in a waterway or a river. So blood flow should be nice and smooth and flowing. And if we put a rock or a stone or build some sort of wall, the water is going to build up against that wall, and the whatever the water is feeding on the other side of the wall is not going to get fed as much. So if we're looking at the brain relies on a lot of nutrients. It relies on a lot of glucose and oxygen in order to function. So if we block the flow of blood, that's the water, if you will, that's delivering all of these nutrients to the brain cells, then we're going to have a problem with the ability of the brain to respond, to sense as well as respond appropriately. So, so that could be what's going on here with this particular individual with Paul and his stroke. So if he's having a cerebral vascular accident or a stroke, it could again be that it began as a clot, and then his high blood pressure triggered, it triggered the formation of the clots in the arteries. And then at the same time, stress has built up. Anything could happen. Something as simple as standing up too fast, or making a quick movement, or hearing news that triggers the fight or flight kind of stress response that increases heart rate and blood pressure normally. So if I already have a patient that has problems with heart rate and blood pressure and they get stressed out, it exacerbates their problem. So anyway, that high blood pressure could have triggered those clots to form, triggered those clots to get loose, and travel up to his brain. So that's what we're dealing with there. Wonderful, huh? And again, this is fairly common actually nowadays, especially with the all-American diet, which includes a lot of fatty foods and high sodium foods, and not a lot of exercise, a lot of stress, and not the right amounts of sleep, and so on and so forth. So let's see. So anyway, we got to get Paul out of there and get him to the hospital. Um, so we run a CT scan and an EEG. We're going to do an EK or an echocardiogram as well. He's in ICU. CT scan. Paul suffered from an ischemic infarction of the left anterior cerebral artery. So left side anterior, so toward the front, which again, remember, frontal cortex is your motor cortex, or frontal lobe has your motor cortex. So left anterior cerebral artery. Okay. So in other words, a blood clot in one of the major arteries of the brain caused Paul to suffer a severe stroke. Since the blood clot that caused the stroke didn't originate from the brain, it's called an embolism. So an embolism is a clot that travels. An embolus is the clot. So, embolism is a clot that originates from a part of the body, travels in the blood through the circulatory system, and eventually ends up in a different part of the body. In his case, it ended up in the ACA, or the anterior cerebral artery. These are less common. The symptoms he suffered, such as slurred speech, numbness, dizziness, confusion, hemiparesis, which again is weakness or on the one side of the body, were commonly associated with people who suffer from stroke. So the doctor does a physical neuro exam and determines the severity of the damage. She's looking at his reflexes. So she checks his quadriceps reflex, which is a simple knee jerk reaction. And they tap your tendon, your quadriceps tendon. They also call it called the patellar tendon specifically. Yeah, so positions herself. She tapped Paul's right knee. Hyporeflexia. So again, we've already seen from his CT scans and MRIs that he's got issues on the left side of the brain. So we would expect right side issues, which we see. Left leg responds appropriately. Examine both upper limbs, which respond appropriately. So his arms are doing fine. Okay, so she examined both upper limbs, so his arms, and those appear to be fine. So we're looking at the leg, right leg problem. Paul, can you understand? So Paul smiled and nodded. So he has comprehension and hearing, but he has verbal problems. So immediately suspected left side cerebral damage and motor dysphagia, which is the speech difficulties. So, and again, we can speak because of motor, because of muscle or motor activity. All right, so we're observing medical students puzzled by flaccidity. So the weakness at Paul's right leg. Flaccidity also really shows us that there are proprioceptive problems as well. So it's like a muscle, even when it's not moving, still has some sort of there's some rigidity to it. But Paul has no rigidity at all in his right leg. So the patient wants to know, why are we looking at hyporeflexia and flaccidity, since the CT scan revealed upper motor neuron damage? Shouldn't he be showing hyperreflexia and spasticity? Great question. Why don't you check in on that, and let's get talking about that tomorrow. All right, well, good. Let's see what ends up happening here. Okay, so CT scan. Well, first of all, why are we getting this is just asking you to research these three diagnostic exams. So what is a CT scan, what is an EEG, and what is an echocardiogram. So again, we know a CT scan is a visual X-ray that can determine the severity of Paul's stroke or Paul's event. Let's see. So basically, a CT is it's not as good as an MRI, but it's better than an X-ray. So it's going to get more than just hard tissue, such as bone. We're going to see some other soft tissue as well, which is, again, we're dealing with blood vessels, so we need soft tissue imaging. The EEG shows brainwave patterns. So the electroencephalogram, so we have electro, so we have to have some electrodes. Encephalo means inside of the head, so the brain. So brain electricity gram, some sort of measuring tool. So the EEG is going to show brain patterns. let's see, echocardiogram. It's an EKG. That's going to show electrical activity of the heart. Okay, so pretty straightforward. We're looking at brain electrical activity, heart electrical activity. Then we're going to look at some anatomical structures with the CT scan. All right, this next one says explain the difference between an embolic stroke and a thrombotic stroke. Okay, so an embolus versus a thrombus is what we see. So Paul has an ischemic stroke caused by an embolus. Remember, an embolus is a traveling blood clot. Okay, so anyway, Paul's, let's see, he's has an interruption of blood flow to the brain caused by a blockage due to a lack of oxygen. And could have he had to they use the word infarction, so we could have irreversible brain damage with neurological deficits. Thrombus so what's a thrombus then? So the thrombus can cause the stroke. That could actually be the point of origin. So a thrombus is a blood clot that it stays put. So he had an embolic stroke, which means the blood clot traveled from somewhere else. So it likely came from the heart. In fact, the left side of the heart ejects blood and through into the aorta, and the aorta branches and heads up to the brain and then heads down to the rest of the body. So if he had a blood clot within the heart tissue, it could have come from inside of one of the coronary arteries that surrounds the heart, because that has an entry point near the aorta. So if it likely, if it went to the brain, it would have come from the left side of the heart. Normally an embolus detaches from somewhere else in the body. Typically we see an embolus traveling from the lower legs, and it's usually going to be a venous embolus. So it's coming from maybe veins of the lower legs, and again, the clot formed in the vein or the artery because of excess stress on the lining of that, the inner lining of that vessel. So if we get a blood clot loose from the legs, it's going to travel through the venous circuit, and typically, it's going to go into the right side of the heart first, because remember, the venous circuit heads to the right side of the heart before the blood gets sent out to the lungs. So once that venous blood heads back to the heart, if it's carrying a small blood clot with it, an embolus, then the right side of the heart pumps the blood over to over to the lungs. And oftentimes that's where we see the embolism occur. So the embolism is the actual event of the embolus, ceasing its travels. So many of you have maybe possibly heard of a pulmonary embolism. So that's much more common than a cerebral embolism. So anyway, this situation with Paul, we've got an embolus. Now, could the embolism or could the embolus have traveled from the legs to the right side of the heart, to the lungs, left the lungs, went to the left side of the heart? The left side of the heart ejects it up to the brain? Sure, yeah, that has happened. But because Paul has high cholesterol levels, we can pretty safely assume that the embolus originated somewhere in or around his heart, and then traveled up to the brain. Now, a thrombus is if Paul had that's like a brain tumor almost. It's not not a brain tumor. That's glial cells typically, but but if Paul had a thrombotic stroke, that would mean the blood clot originated in his brain and formed the dam right where it's located. Anyway, that's the difference. Either case, blood flow is stopped. So it really doesn't matter, excuse me, per se, whether Paul had a thrombotic or an embolic stroke. The fact is, a blood clot, they're both blood clots. One traveled there, one grew there, originated there. That's all you need to know. Okay, number 3. Where does the ACA or anterior cerebral artery originate? What structures in the brain does the ACA supply? So again, you can Google that and find the map and the breakdown or the pathway to get to the ACA. So again, we've got the you could start at the left side of the heart, ideally maybe at the left ventricle, injecting through the aortic valve into the aorta. Okay, and then we have the aorta branching into 3 separate areas. So you have the left subclavian, remember, goes out to the left arm, and the brachiocephalic right away takes us to the right side of the brain and the right arm. And then you have the left common carotid. So that's going to go up to the left side of the brain or the left side of the head and face. And then you have that that left subclavian that's going to go out to the left arm. So so the brachiocephalic goes up to the right side of the brain, and the left common carotid goes up to the left side of the brain. We know Paul's got a left brain issue, so we could possibly start at the left common carotid. And the left common carotid branches as it gets right up into this area of the body. And right around the TMJ area, we see a split where the common carotid becomes the internal carotid is one fork in the road, and then the external carotid is the other fork. So because we're going inside of the brain, we're dealing with the internal carotid artery. So as we leave the left side of the heart, the left ventricle, going into the aorta, into the left common carotid artery, we then branch into that left internal carotid artery. And then let's see, then you're going to have a branch arising as this anterior cerebral artery, and that's going to continue as the middle cerebral artery. So the AC, which we call the MCA. So you're going to have an anterior, so the internal carotid is going to branch into the anterior cerebral artery. And then the other one continues to be the middle cerebral artery. So you have the branches, the carotids go up, and then one stays outside the brain, kind of supplies the face. The other one goes into your brain, the internal carotid, and then that's going to branch. We're going to have an anterior branch and a middle branch and a posterior branch. So we're dealing with the anterior branch. So the anterior branch is going to go up, and it's going to supply the superior and medial portions of the frontal lobe of the brain, as well as the parietal lobes. So based on Paul's behavior, we know that the frontal lobe and the motor cortex and the speech center, those are all going to be that prefrontal cortex. We're going to be right where the parietal and frontals meet. We're on the left side for Paul. So we do a CT scan, and sure enough, we can see that the pathway of blood flow that feeds all of that is where the problem lies. So anyway, the olfactory system, so the sense of smell, could be affected as well. Again, the precentral cortex or precentral gyrus is going to be where that primary motor cortex is. So, so anyway, that's again, that's at the fissure where the frontal and the parietal lobes meet. So the first section of frontal lobe we call the central cortex, or the precentral gyrus. That's the motor cortex, and he's having motor issues. Let's see. You may want to look into the Circle of Willis. It talks a little bit about that. A lot of brain. The other thing we have are called brain aneurysms. That's when an actual balloon is forming. You have a blood vessel in the brain for a brain aneurysm. The blood vessel itself, the wall is becoming thinner and thinner. Whoa, disappeared. Thinner and thinner and thinner until it ruptures like a balloon. So the aneurysm is actually the balloon blowing up in the breach, the weak point of the artery. When it ruptures, we say the aneurysm has burst or the aneurysm has ruptured. That an aneurysm can potentially be discovered before it ruptures, and that's a really good thing, right? So, in Paul's situation, because he's had he didn't have an aneurysm, but he's a definitely a prospect or a contestant for having one because of his high blood pressure and hypertension problems, his hyperlipidemia. So anyway, he could also be a candidate, I should say, for uh, aneurysms forming. So why is an embolic ACA stroke less common than a middle cerebral artery stroke? Well, again, well, a couple of reasons. Embolic stroke in general in the brain is less common than a thrombotic stroke or an aneurysm. But why he had a anterior cerebral artery? Why is that less common than a middle cerebral artery? Well, primarily, again, if you look up the Circle of Willis and you look up the basilar artery and you look up the branching that goes on, you'll see that there's almost a direct line from the left side of the heart, the left ventricle, up through that left common carotid into the internal carotid, heading straight up toward that middle cerebral artery. So that's where we normally would see a stroke because of, again, there's more of a direct transition or a direct line of blood flow heading to the MCA, or the middle cerebral artery. Okay, if a blood clot was located in the left ventricle of the heart, describe a probable pathway. We kind of did this already, right? That would travel, so probable pathway. So we've got the ascending aorta, right? So we leave the left ventricle into the ascending aorta, the aortic arch, left common carotid into that internal carotid, and then finally into the ACA. Yeah. So path of blood, you get to revisit that for this particular case study. So that's kind of nice. Why was Paul able to comprehend but had difficulty in responding? So left brain injuries, we know he's got left brain injury issues, can affect language and speaking. He's unable to verbally respond because the neurons communicating with we call it the Broca's area, lost blood supply due to the stroke. So again, we built up a dam, blood supply past that dam, or past where the clot was, meant that there wasn't, we weren't getting nutrients delivered distally, and in Paul's case to the Broca's area, that prefrontal cortex. So he has difficulty producing speech. He can comprehend speech because that's in Wernicke's area, so more the post frontal or post central region, so more in the parietal area. So anyway, they're neighbors to each other, but Broca gives him the ability to speak. Wernicke's gives him the ability to comprehend speech. So Wernicke's is more of a sensory region. So comprehending speech, that's the sensory of sound coming into the ears, traveling up, right? So sensory goes in, motor comes out. So he can sensory hear what's going on, but he can't motor respond what he wants to say going outwardly. All right, 7. What do you think the medical student will report back to Dr. Vasquez? Um, so he has hemiparesis, displaying the muscular weakness on one side of the body due to the location in the brain where the stroke occurred, right? So it caused that injury on his left side, caused some right-sided weakness. Post immediately, so right after this event, so Paul's, remember, we're still in the early stages of him having his stroke. So immediately, post upper motor lesions, lower motor neuron regions. So immediately after something happens to these upper motor neurons, so we've got lesions forming because of the lack of blood supply. Okay, the lower motor neurons will oftentimes go into shock because it's like they're used to constantly getting this cascade of stimulus, even on the proprioception front, where you are getting the stimulus going up, the motor response is just stay erect or stay moving this way or that way. Okay, so when that signal stops, the the domino that tells the lower body to do what it needs to do, it's not getting stimulated. And it's in a state of shock. It's saying, why am I not getting stimulated? Well, it's because prior to you, the domino before you isn't falling either. So anyway, the pre motor cortex wasn't working. So signals weren't being sent to the lower motor neurons that control the movements of the lower body. So, um, so anyway, um, early post stroke, we oftentimes see this. Um, Now, will it change over time? Probably, yeah. Most cases it does. Paul's probably going to have to undergo some physical therapy and things, occupational therapy and things like that to reorganize everything. But yeah, I'm sure his ability to walk and have movement on his right legs or with his right legs, that should come back within a few months. Let's see. Paul got moved from ICU 3 days after his stroke. Rehab program involves multiple hours of active therapy, helping him gain more function and be a little more independent. He's attending speech therapy. So those will be upper motor neurons. And physical and occupational therapy for his lower motor neuron, right leg hemiparesis. Physical therapists address isolated movements and rehearsed complex movements such as transferring from bed to chair. So isolated movements for Paul would be just for his right leg would be trying to like make a fist, if you will, with his toes or kind of flex his toes and then extend his toes and then trying to get him to dorsiflex and plantar flex his ankle and foot and heel and then trying to or invert and evert his ankles. um, even just rotating his hip, bending his knee, any of these basic movements that are isolated. And then more complex movements. So, putting his foot on the floor, standing up, walking to the bed, getting up into his bed, and then getting out of bed and going over to a chair. So, what you and I take for granted, a person or a patient who's had a stroke, they're going to have a lot more difficulty doing some very basic movements. Let's see. We're also going to see sensory stimulation to encourage the limb as well. So he's going to get some massage therapy on the limb. He's going to get some cool and warm therapy. He's going to get fuzzy, sharp, different sensory stimulation as well. They put some sensory electrode stimulators as well on Paul's legs. And then again, speech pathologist for word repetition, reading exercises. All right, so a couple weeks after all of this, another neuro exam, Paul's muscle strength, quad reflex, tapped his isch. She noted hyperreflexia and signs of spasticity. Oh, in other words, Paul now displayed an exaggerated knee jerk and tight, stiff muscle tone in his right leg. She evaluated the left leg, which is normal. So he went from flaccidity and hyporeflective to now hyperreflexive and hyperspastic. We'll talk about that in a second. Paul's meals loaded with fruits, vegetables, high fibers. Teresa noticed ritual-like taps with his fork, noting his curiosity. She was unfazed. While noting this curiosity, she was unfazed. After lunch, to watch television, for the remote, spectacle, she usually reached her house. She grabbed the remote. He had not let go. What are you doing? In a halting, slurred speech, Paul had a hard time replying. Managed to say, didn't mean to happen. Are you not letting go on purpose? And he says, no. So, so basically, he grabs the remote, hands it over, and then he can't let go of it. So he's got the grab down. He doesn't have the relax down. Immediately intrigued, Paul's right hand seemed to be no longer in his control, to have a mind of its own. It always become bothersome. The Teresa reported that had been happening since the stroke. Right hand activity appears to be unwanted, so Paul has no control over his right hand. No signs of injuries. It's the first patient with alien hand syndrome. Wonderful. So this is inside light that we weren't expecting. Having only read about it in literature, treatment for alien hand syndrome is limited since it's extremely rare. Occupational therapists began to work with Paul to keep his foreign hand distracted when necessary by holding an object to help decrease unwanted movements and gestures they perform. After a few weeks, he was transferred to rehab nursing facility where his post-stroke recovery continued for several weeks before he could return home for outpatient rehabilitation. Whew. So he's bouncing around. He's started 3 days or so in the hospital, then spent a couple weeks in physical therapy, rehab. Now he's being transferred to a nursing facility. And then after that, over the course of his therapy, he could use a walker. Physical therapist can work on his gait. That's how he's walking, how fast he's walking. Occupational continue work with Paul and skills after, although Paul is speaking slower and incomplete sentences, he'd made progress in improving his dysphagia. The speech therapist worked to help him develop problem solving and social skills to cope with the after effects of a stroke. All right, so a couple of things happen there. We've got alien hand syndrome. That's rare, but uncontrolled involuntary hand movements. One hand is not under control of the mind. The person loses control of the hand, acts as a mind of its own, basically. Common for individuals who have a sense of disconnect with the limb. So obviously with Paul's situation and his cerebral vascular accident, he's having problems connecting his brain to his arms and legs. So could have a lesion, that in that specific area. Um, let's see. So anyway, you can look up alien hand syndrome and see what you find on that. Number two, reason behind the change over the first couple weeks, post-stroke and Paul's quadriceps reflex. Again, those upper motor neurons in the precentral cortex or precentral gyrus were damaged, right? Immediately after that damage, they're not sending any signals to the lower motor neurons. So they are also, by default, they're in a state of shock as well. We're not really sure why. So we know why that the flaccid nature and the lack of movement from those lower. We know why that happens now, because of what we just said. Now, the reason behind the all of a sudden, remember, he started having more spasticity, more hyper reflexive behaviors. Um, so they're not entirely sure, but I think what makes sense to me is that you have uh, hypo-reflexive behavior as a result of not being stimulated anymore. So the lower motor neurons go from a constant state of stimulation to nothing. And so as time goes on, um, so what they start doing is kind of after the initial shock is worn off for them, these lower motor neuron cells, I think they probably start getting they start to upregulate or increase some of their own receptors to receive stimulus. So they're basically saying, well, maybe we don't have enough receptor sites. Maybe our receptor sites are faulty. So I think they probably start creating, laying down a lot more receptor sites. And so then once time kind of takes care of itself, and then we start to see some stimuli being delivered from the precentral cortex down to the lower motor neurons. They're sitting there now with what normally would be 50 receptor sites. Now they have 500 receptor sites that they've been preparing. And so they basically get flooded they allow themselves then to be flooded with stimulus. And then so they then send a hyper responsive stimulus down to the legs. So I think it's probably something like that is going on. Could be the inhibitory neurons are damaged too, and so as they get built back up, they express themselves like being brand new, newborn. I don't know. But I have a feeling it's more or less the lower motor neurons all of a sudden don't get a signal, so they think, oh my gosh, we must need to have more receptor sites. So they start building up a ton of receptor sites, and then once the signals start coming back down, they have all these receptor sites getting satisfied, and that triggers the hyper reflex that we would see and the hyperspasticity. All right, lastly, if you're Paul's neurologist, what do you tell him about the long range outlook? So obviously, Paul is going to be going through quite a bit of rehab and physical therapy and speech therapy. Um, he could probably expect to regain some function of his certainly of his right leg. He'll regain some function of his of and control of his alien hand. But the neurons that were lacking nutrients and including oxygen and glucose for the period of time between the stroke occurring and then the neurologist and the neurosurgeon getting blood supply rerouted, that amount of time that those neurons went without nutrients meant that they probably died, and neurons don't regenerate. So, but existing neurons that were able to continue to thrive and stay alive, they can make new connections and maybe fill in some of those gaps through glial cells or glue cells, which can regenerate. So, will he have the same movements and speech patterns and life that he did before the stroke? No. Will he be completely debilitated? Probably not that way either. So, complete recovery is highly unlikely. So, the physician would want to be straight with that because neurons don't regenerate. However, I think Paul, with the right kind of therapy and the right kind of attitude and the right kind of nutrition, will probably be okay in developing and reacquainting his body with certain movements and speech ability. So anyhow, that is the story of Paul and his CVA, or cerebral vascular accident. At this point, I think, let me go over here. I can't remember exactly. Let's see what we're at. Yeah, we'll wait till next week to do this one. This one's a little more intensive. So we'll meet in Zoom again, I think next week. I'll send out an announcement, but I think I'll do a Zoom again next Wednesday. And we'll go through case study 8 on renal physiology. And then we'll see where we're at, and we might have time to do case study 9. But other than that, I'm going to sign off for now. And if you have questions, please email me, and have a great week, everybody.